So here I am again. Actually, I would have loved to give this talk after Dr. Somshekhar's talk, because he was to give the basic concepts on molecular classification, but he's busy in the other session. So I will first speak on recent developments in advanced and recurrent endometrial cancer. Like I said earlier, endometrial cancer was supposed to be a very simple and best to have gynae malignancy, but it is not so now. And the recently released data by ICMR shows that the incidence of cancer, 1 in 9, is there a pointer here? Yeah. Yeah. So 1 in 9 people in India are likely to develop cancer in their lifetime, which is a good number, too good a number, I would say. And 1 in 190 are at risk of developing uterine cancer, out of which 80 to 90% are endometrial cancers. If you look at the cancer trends in India, incidence of these cancers are on a rise: breast, uterus, ovary, lung, and prostate. Cervix, esophagus, stomach, and hypopharynx are decreasing. So uterine cancer is again increasing. Just to give a background, globally, the incidence of endometrial cancer has increased by 0.69% per year between 1990 and 2019. In patients with advanced and recurrent distant disease, overall 5-year survival rate is only 17% as per American Cancer Society. And endometrial cancer risk stratification based on histological type, grade, and stage, which we have been following till now, is seen to be quite inconsistent and imprecise, leading to over and under treatment many times. So molecular classification has now come in, but still there are a lot of confusions regarding this and its integration into the management, but we will try to talk about it. Dr. Somshekhar would have talked about the molecular classification. I will just elaborate the names. It is highly reproducible and with good prognostic value. And this uses basically 4 molecular subtypes, namely Pol mutant, MMR deficient, P53 aberrant, and NSMP, which is no specific molecular profile with normal or wild type P53. And WHO recommends integration of molecular parameters in all pathology reports now. So this basically you can see here, these are the low-grade endometrioid carcinomas. This is currently applicable only to type 1 or endometrioid carcinomas of the endometrium. And these are the high-grade carcinomas. And here the inner circle is showing the molecular classification. So copy number high and MSI high are included in the high-grade endometrioid carcinomas, whereas MSI and copy number low are in the low-grade cancers. And these are the molecular pathways which lead to the expression of molecular indicators. Now, for the purpose of management, NCCN uses the following categories for delineating endometrioid cancer treatment groups. These are disease limited to the uterus, suspected or gross cervical involvement, and suspected extrauterine disease. So if you talk about uterus confined disease, this includes stage 1A, stage 1B, and stage 2. If you talk about extrauterine disease, this includes 3A, 3B, 3C, and 4A and 4B. 4B is mainly individualized management, but up to 3 and 4A is blanketed in advanced stage endometrial carcinoma. So this is a busy slide like all NCCN slides. They do give, I will take you to the flow chart. I think this will be easier for everyone to see. So if it is a surgically staged stage 3 and stage 4 endometrial carcinoma, you can individualize the treatment. In stage 3A, systemic therapy and or EBRT plus minus vaginal brachy. 3B, systemic therapy and or EBRT plus vaginal brachytherapy, because here vagina and parametrium are involved. 3C1, pelvic node positive. 3C2, para-aortic node positive. Systemic therapy is preferred with or without EBRT or with or without vaginal brachy. In 4A and B, if it is completely debulked disease with no residual disease or microscopic abdominal disease, then we can go ahead with systemic therapy plus minus EBRT plus minus vaginal brachytherapy. If it is 4B with residual disease or even 3 with residual disease, treatment would just be more or less palliative, especially in 4B. So these are, just to complete the list, these are the type 2 or serous carcinoma, clear cell carcinoma and carcinosarcoma, where in stage 1A, you can either observe or give systemic therapy with or without RT. In rest all stages, chemotherapy with or without RT. But these are not included in the endometrioid NCCN. Now, PORTEC-3 was a landmark trial on adjuvant chemoradiotherapy versus radiotherapy alone in women with high-risk endometrial cancer. And the patterns of recurrence and post-hoc survival analysis were studied in a randomized phase 3 trial. And PORTEC showed that the radiotherapy, the chemoradiotherapy arm resulted in better overall survival and failure-free survival in all patients and in patients with stage 3. See, this is the blue line is the chemoradiation, which is better survival overall and failure-free survival in stage 3. So here they established the definite role of chemotherapy along with radiotherapy in advanced stage endometrial cancer. Also similar were the results for serous cancers. If you look here, the recurrences, because what we are concerned with in management is to define what would be the pattern of and the incidence of recurrences to decide on the prognosis for the patient. So basically, if you look at the number of vaginal recurrences, they were equal in both chemoradiotherapy and radiotherapy arm, but the other recurrences, the pelvic recurrences, the distant recurrences, and total number of recurrences were much less in the chemoradiation arm as compared to the only radiation arm. Hence, the chemotherapy was said to be an integral part of management of advanced. Almost 11% improvement in overall survival was seen with chemoradiation, with the addition of chemotherapy in stage 3 disease. This is another trial which has recently published its data, GOG 258. Now, they studied adjuvant chemotherapy plus radiation versus only chemotherapy. In the chemoradiation versus only chemotherapy in advanced stage endometrial cancer. And they found that there was no difference in relapse-free survival with only chemotherapy versus chemoradiation. So maybe only chemotherapy will become the future norm for advanced stage endometrial cancer. We do not know yet about it. Not in the guidelines yet, but yes, maybe a thing of the future. As you can see here, almost the similar results, chemoradiation, better results with only chemotherapy in some of the cases. Now, overall numbers are almost same. I don't think this slide is visible from far, but recurrences, overall numbers are almost same with chemotherapy versus chemoradiation. So these are the NCCN chemotherapy recommendations for recurrent metastatic or high-risk endometrial cancers. Actually, all studies most of the studies that are done, they take as an umbrella metastatic as well as recurrent disease. So the overall recommendation is that multi-agent chemotherapy regimens, out of these, carboplatin paclitaxel is the most preferred one as of now. I think my medical oncology colleagues can tell us better about these studies and these findings. And if you use single agent, cisplatin is the one that is the most used. So as far as surgical management of advanced stage of CA endometrium is concerned, treatment is individualized based mainly on disease extent at presentation and patient's performance status. And in future, we will incorporate molecular profiling into this. Surgery is often the mainstay of treatment till stage 3 disease. And as far as adjuvant radiation is concerned, all patients with positive pelvic nodes will receive pelvic radiation. All patients with para-aortic and common iliac node involvement will require additional extended field radiation. Adequacy of surgery has a bearing on outcomes, and abdominal failures in stage 3 have again prompted evaluation of WAR. WAR is whole abdominal radiation. Earlier on, it was used but was dropped because of a lot of toxicity issues. Again, this has come into studies. Now it is being studied because a lot of abdominal failures were seen in stage 3 after treatment. As far as I just mentioned this here for the future. Molecular analysis of POTEC3 suggests that MMR deficient endometrial cancer may have an increased sensitivity to radiation. So again, molecular profiling might be a guide as to what specialty to use for future. And in advanced MSI high endometrial cancer, improved progression-free survival was seen with chemoradiation versus only chemotherapy. So in this group of patients, maybe chemoradiation will be better as compared to only chemotherapy as seen in GOG 258. So we might see certain changes in the future. Now, this I have already told you that POTEC3 showed superiority of chemoradiation to radiation alone, and GOG 258 concluded that chemoradiation was not associated with longer relapse-free survival than chemotherapy alone in stage 3 and 4A. These are the various trials that were done. This was GOG 258, which showed the non-inferiority of chemotherapy alone. Now, as far as there are certain cases where we have to give radiotherapy alone, which is when patient is unfit for surgery or disease is too advanced for surgical debulking. Total dose of radiotherapy alone is similar to that for carcinoma cervix, but a larger tumor-directed dose is given to the uterine cavity. The Walt application along with external beam radiation, and overall 5-year survival rate is no more than 45 to 60%. NCCN has also given certain recommendations in its principles of pathology, and it says that estrogen receptor testing is recommended in the settings of stage 3 and 4 and recurrent disease. Always when a recurrent endometrial carcinoma comes, please again test for estrogen and progesterone receptors on that tissue. Also, you can consider HER2 IHC testing in TP53 aberrant endometrial cancer regardless of histotyping. Hormone therapy is also given in disseminated metastatic or recurrent disease. Progesterone is the first line therapy. Tamoxifen and other SERMs are an option. Aromatase inhibitors and tamoxifen form the second line or second preferred hormone therapy. Medroxyprogesterone acetate, megestrol acetate are the most commonly used, and tamoxifen can also be given for a few months, although response rates of up to 33% are seen, but for short duration only. So now this is POTEC4A trial, which is now an international randomized trial of molecular profile based adjuvant treatment for women with high risk endometrial cancer. This is ongoing. We will see the results in 2023, and this is the schema that they are following. In all stages, they are doing molecular profiling also and correlating with the adjuvant treatment. We will see which is best for which molecular profile in future. Now, like I said, most trials have included recurrence along with metastatic disease, but there are some basic concepts that we must know about recurrence. So 80% of recurrences happen in first 3 years, and about 50% of patients have locoregional disease, 25% present with distant recurrence, and remaining 25% can have both local and distant recurrence. Several studies showed a relapse-free survival of 60 to 70% after complete debulking and adjuvant radiation. So complete surgical treatment and proper adjuvant treatment are very, very important. Median 5-year survival of 55% is seen after pelvic recurrence in most studies, and only 17% after distant metastasis. These are the, as you can see, with increasing stage, the incidence of recurrences increases, and also the histology has a bearing on the type 1 or the endometrioid have less recurrences, but as you go towards serous, clear cell and other cancers, recurrences increase. So these are the recurrences after chemoradiotherapy and radiotherapy alone. This I think I've already told you. Again, NCCN guidelines, we will just go through a flow chart for this. Now, I will just highlight here, when we face vaginal vault recurrence in a previously irradiated patient, we must go for a surgical resection if it is feasible, followed by adjuvant local RT. If the patient is not irradiated previously, we can directly give her an radiotherapy. And but local control with radiotherapy is worse for larger tumors. If the tumors are more than 2 centimeters, you can go for EBRT plus brachy. And but still, I think the local control will depend on the tumor size a lot. Now, there are certain innovations in radiotherapy also, like for vaginal recurrence. Now they give EBRT with elective nodal radiation and brachy boost. MRI-guided brachytherapy has come in to better give a guided radiation, and laparoscopic guidance is being now used for applicator placement, for more precise placement of applicators. When there is locoregional and abdominal recurrence, the norm earlier as far as surgery was concerned was pelvic exentration with curative intent. But there has to be an isolated pelvic adenocarcinoma recurrence after radiotherapy for pelvic exentration. 5-year survival rates after pelvic exentration in various studies were reported to be 56 to 70% with R0 resection. But if the resection is R1 or R2, which is there in most cases because of various factors, then the 5-year survival is only 20%. So to give a 5-year survival of 20%, this procedure is too morbid a procedure for the patient. So we must do justice when we do go for pelvic exentrations. Now, surgical cytoreduction is coming more and more in vogue and replacing pelvic exentration because this is less morbid alternative. Retrospective studies have demonstrated feasibility and additional value. We need more prospective studies. Solitary recurrence, tumor size less than 6 centimeter, and performance status were found to be favorable factors in various studies, and no gross residual disease as always, and negative margins improved overall survival. Neoadjuvant chemotherapy followed by debulking has not been studied so far, but may be considered in individual patients. Further research is needed. Again, for pelvic recurrence, EBRT with the boost, like I said, RT plus CTs or surgery on individualized basis has to be done. Re-radiation is a challenging issue due to toxicity, but is now better with image-guided procedures and stereotactic radiation therapy or MR-Linac. Stereo-guided radiotherapy is also suitable for oligometastatic disease, which is less than 5 total lesions. Then you call it oligometastatic disease. If there is a solitary distant metastasis, there is limited literature. Case reports of solitary splenic, pulmonary, hepatic, and cerebral met resection are available. Favorable prognostic factors were, again, good performance status, long disease-free interval, and clear margins. These are the newer modalities, SBRT, cone beam, CT, and MR-Linac. My radiation oncology colleagues will know better about these. As far as chemotherapy is concerned, GOG 209 has confirmed non-inferiority of carboplatin paclitaxel as compared to TAP regime, which was used earlier but had a lot of cardiotoxicity and other issues. So overall, the response rates of 30 to 35% were seen in women with advanced or recurrent endometrial cancer with various chemotherapy regimens. These are the various trials that were done here. This is the one which proved the non-inferiority of paclitaxel plus carboplatin. Now, newer treatment options are immunotherapy, hormone therapy, and targeted therapy. Various selected targeted pathways are being used. Trastuzumab was used but not yet approved. Selected anti-angiogenic mechanisms were studied, and even bevacizumab was used in some trials but not yet approved. These are the various cytotoxic. These are the hormonal agents which were studied in various studies, anti-angiogenic agents which were studied. These are the emerging targeted therapies. Temsirolimus was used, but again, it is not yet approved. Just 2 minutes. This is an overall chart of how to deal with metastatic disease. You do or recurrent disease, you do an immunohistochemical analysis. If it's an ER/PR positive, then you go for hormone therapy. Again, like I said, progestins and tamoxifen or aromatase inhibitors. If it is MMR deficient or MSH high, then immunotherapy is preferred. Now, the pembrolizumab is approved by FDA, and this combination of livatinib and pembrolizumab is also approved by FDA, and this can also be given in MMR proficient patients. Now, other profile, if there is a profile other than this, then you go for paclitaxel carboplatin chemotherapy. So take-home message is multidisciplinary and collaborative efforts are needed for best outcomes in these complex cases. Gynae-oncosurgeon should be an integral part of the team, and thorough counseling and holistic support should be given to all patients. Thank you so much for your kind attention.